have not been exposed or infected with TB. But as we all know, that is not going to solve the problem. BCG is not going to eliminate TB because we need a vaccine that's going to prevent TB and to protect against TB in multiple age groups and multiple populations. We need to be able to address latent TB. We need to be able to address TB in adolescents and adults. And the current vaccine will not do that. So we are working, the TB vaccine field is working on developing vaccines that can be used to address all of TB in all of these different groups and populations. A new, more effective vaccine could be safer and more effective in preventing TB in children and adolescents and adults, including people living with HIV, protect against all forms of TB, reduce the cost and burden of TB on national healthcare systems and economies, and contribute to global efforts to control TB. This is some modeling that was done by Chris Dye at the World Health Organization, which just gives you an idea of the potential impact of a new TB vaccine. And looking at a vaccine that could have the potential to prevent TB in multiple populations through mass vaccination, that's the purple line you see at the bottom, could really have a significant impact over the next 30 to 50 years. There's been a lot of progress in the field of all of the new tools. I just want to spend a minute on giving you an example of the progress in the field of TB vaccine development. A decade ago, we didn't have any preventive vaccines in clinical trials. We now have 12. A total of 15 have entered the clinic and a dozen are currently being tested. We're in phase 2B proof of concept trials where we'll get the first indication of efficacy of new TB vaccines, and we should have that data early next year. In addition to the clinical trials, which is what we often focus on because that's what's telling us what's coming down the field and what we may have in the field in the coming years, there's also a robust pipeline of second-generation candidates. As I was saying, work continues. We're continuing to build on the knowledge that we have to try to develop better and better candidates. Vaccine development also comes with capacity and infrastructure development. The large-scale trials that need to happen for TB vaccines happen in the countries with the highest burdens of disease. So while we're developing these candidates for clinical trials, we're also working with local research institutions to develop the capacity to run these trials. Epidemiological cohort studies are happening in these countries, which provide important baseline data. And we're already looking at regulatory pathways and market and economic research so that we can better understand how to get vaccines adopted and laying the groundwork to accelerate the adoption of new vaccines. So the past 10 years, you see a lot of things have happened. And we're sort of at a pivotal stage in TB vaccine development where we focused over the past decade on finding those novel vaccine candidates, those novel ideas, turning them into products and getting those products into the field. We now have a pretty robust pipeline, and as I said, a dozen candidates in the field. Over the next decade, we have to continue to build on that progress, but we also have to look towards the future, towards the eventual adoption of new vaccines, and to really lay the groundwork and be thinking about that. So towards that end, the Stop TB Partnership Working Group on New Vaccines just yesterday launched a new blueprint for TB vaccine development, a strategic blueprint for the next decade, and you all have brochures on your table that I encourage you to take with you. And this was the TB vaccine research community coming together and really examining what are the critical issues and challenges that need to be done over the next decade to reach our goal, but also recognizing that this is a daunting task and one that no organization can do by itself. So it emphasizes the need for collaboration as well as innovative approaches. So when we talk about R&D, we do have to talk about the resources required. This shows the estimated resources required from, you can't quite see it there, but this is from the Global Plan to Stop TB 2011 to 2015, which shows the resources that are required to, over the next 5 years, towards the goals of developing these new tools. I know that this seems like a very daunting number, and it is, but I also want to encourage you to think about this not just in terms of dollars, but in terms of innovative approaches to provide the resources that are needed. One example of that is from our U.S. government here, where recently the National Institutes of Health opened up the vaccine trial sites that they've developed specifically for HIV vaccines. They've now opened them up for TB trials. So there are TB vaccine trials now happening at these sites, as well as TB drug trials, which provides a huge cost offset for those of us who are developing products by providing the resources that already exist and that the U.S. government has already invested in and leveraging them across disease areas. So look, I encourage you and I encourage agencies to look at where other resources like that exist. What are the assets that we have that we can leverage across disease areas to contribute not just to the TB R&D funding needs, but also to global health overall. And this also, just in terms of funding, there's been a tremendous increase in funding for TB R&D over the past 5 years, which is greatly appreciated by all of us in the field. However, you'll see a troubling pattern towards the end. It went up and up and up, and it's starting to flatline. We had a small increase between 2009 and 2010. And investing in R&D is something, developing these new tools is so critical, and the needs are great. So this is a concerning trend, and one we hope that will be reversed. And again, looking at all of the different ways that we can invest in R&D. Okay. So just to summarize, as we've talked about, new TB vaccines and drugs and diagnostics are critical to controlling the epidemic. And a coordinated approach is required that promotes collaboration and minimizes overlap. There's been significant progress, but with progress, as the tools advance farther and farther down the field, development becomes much more expensive, and progress will soon outpace the resources available. So new tools do need to be a global priority. We do recognize, again, that the resource needs are big, both for research and for implementation, but it's so critical for TB, and with the numbers of people getting sick and dying each year, we can't afford not to do it. So with that, I will turn it back over to our moderators. Thank you.
I think I need hazard pay for trying to operate the computer. So, just one maybe quick historical point, if you're indulging me, before we move on to our last speaker, and that is a question I'm sure you all have been asking the entire time we're here, which is, why is World TB Day March 24th? And the reason is that's the date on which Dr. Robert Koch, a German researcher, announced that he discovered what actually caused tuberculosis, the bacterium, and he had sort of identified and isolated it. And I only bring that up because the basic technique that he used to identify it is still more or less the same technique that we use to diagnose tuberculosis around the world today, and that was 130 years ago. So it really underscores the lack of progress, really in the past century, in the development of tools to fight tuberculosis, and it makes sort of all the more amazing the progress that's been made just in the last 10 years on all of these fronts. So for last but certainly not least, I want to welcome Lucica Ditiu to talk to us, who is was appointed the Executive Secretary of the Stop TB Partnership in January 2011. She's a native of Romania, and she is a physician and researcher who has devoted her career to improving the lives of people in communities heavily burdened by tuberculosis. She began a career at the World Health Organization in January 2000 as a medical officer for TB in Albania, Kosovo, and Macedonia, and in 2006 was selected to be a medical officer in the TB unit of the European Regional Office. In 2010, she joined the Stop TB Partnership Secretariat in Geneva to lead the TB REACH initiative, whose goal is to improve access to TB treatment among poor and vulnerable populations. She's a pulmonologist by training, and among other distinctions, in 2004 received the National Order of Merit Medal for Medicine in recognition of her efforts on behalf of the Romanian TB Control Program and the Ministry of Health there. And I also just want to say that I think that she's brought a particular sort of activist spirit and energy and passion to the field of tuberculosis and to the Stop TB Partnership, and we welcome her. Thank you.
Thank you so much. First of all, thank to the colleagues that organized the meeting here. I'm extremely honored to speak with you. Thank you all taking the time to be here with us. And I want to thank to our colleagues that traveled from their countries to share with us their stories and as well their experience in the field. I'm extremely honored to speak here with you, but I'm lucky in a way because I'm at the end. I know what the others said. You know, you had time to eat and drink a bit, so everybody's a bit more relaxed. So I hope we will be, I'll be able to sum up in a way that, you know, will raise many questions from you, and I hope we will be able to answer that. You know, John already said that, but, you know, if Robert Koch joined us in the room here, he will be kind of actual. He will not be surprised by the tools we use, because indeed we still, a big time, use the microscope to diagnose tuberculosis. Our newest drug used this time is 60 years old. We have drugs that we are using which are older than that, but the newest that we use right now, and we heard all the great things from Jennifer, is pretty old. And the vaccine, the only one that we have, and we will have for several years, for sure by 2015, which is the year of the Millennium Development Goals, we will still use a vaccine that is 100 years old. So there are not big differences from how this family here, that is a family which was one of the Western European sanatoriums around the 1880s when Mr. Robert Koch discovered the Mycobacterium tuberculosis, were dealt with. The drugs are of course different, and we are of course not sending people in the sanatorium to enjoy the sun, but otherwise things are pretty similar. So we did big advance in tuberculosis, and we will speak about that. And I want to make it very clear from the beginning for all of you here that the main funder and the main driving force in all the achievements that are happening in TB right now is USG, with different platforms that were funded, with different mechanisms, but let's be very clear, that's because of USG that we are where we are. And we did great steps, and you will see how much we achieved so far. But I want to say that one of the things that, it's the fact that globally, we have TB with us for thousands of years. And I think it's a bit of a failure of mankind in a way, and not just our generations now, that in spite of having that, we have 1/3 of the world's population is estimated by WHO to be infected with TB, having the bug somewhere dormant in the body. We have still almost 1.5 million people that are dying with TB every year. And TB is the second largest killer after HIV/AIDS. And you already heard from Dr. Ariel here that we have, every year, we estimate that we have around 9, let's say roughly, million people with tuberculosis, but still we are able to find just 6 million of them. So there are 3 million people that we are unable to find, diagnose, and put on treatment for tuberculosis every year. And it's one thing that these people are there out, but it's also something that we need to be aware, because there is something we all share, even here in this room, and that's the air. TB is an airborne disease. As far as you breathe, you are at risk. So unless we have that very clear in the head, that we are all at risk, we want or not, and unless we treat our neighbors, our friends, our families, our colleagues, we will all be at risk sooner or later. And I'll go back to that statement again. This is a nice photo taken with some cured patients. The entire family was having tuberculosis. We decided this year to bring into attention the TB in children and TB in women. TB in children is one of the areas that was neglected, and we can do much more on that. We still have at least 500,000 children that are becoming ill with TB each year, and the drama is that there are 200 children that are dying every day. And that in the conditions that tuberculosis is a curable disease. We have treatment for it. It's a long, unpleasant treatment, especially for children. It's a 6 months treatment, the one for normal TB. We don't have formulations for children, which means that, unfortunately, in many, many of the countries, we still crush the pills, we mix them in a syrup, and we try to make the child to take them. And that's for all of you, or for those of you having children, that's not that easy. And as a parent, having your child sick and not feeling well, knowing that you have to go through these 6 months, that in the case that you have access to care, you have access to diagnosis and to treatment, that I can tell you is a tragedy. As you can see, TB is the number, as you heard already, TB is the number 3 cause of death about women of childbearing age. So that's why today we actually launched this childhood TB advocacy campaign together with WHO and many other partners in order to bring into attention of the world the drama that the children with TB are facing, and the fact that when you speak about stopping the death of children from infectious diseases, TB is one of the causes, and TB is a low-hanging fruit because it is very cheap to treat it, and it is possible to do it. Not only that TB makes children suffering, but for those of you that know a bit more about TB, when you are a small child, the forms of TB that you are making are very different than the ones of an adult, and one of them is meningitis TB. And that's a drama. And meningitis leaves big sequelae for those that are having meningitis for the future if they survive. So it's not, and you know, we don't have here Dr. Stark from Texas that was speaking yesterday in the House. But I was shocked, and I don't know how many of you are aware, that he had 33 patients already this year with tuberculosis, and he sees a lot more children. He deals with children with TB here in the States in his hospital, and there are more and more children with TB coming up. So it's not only the drama of the fact that you have to make them diagnosed and treated, it's also the drama that if they are sick and they have a very special form of TB, you can have a tragedy for an entire life. And one of the things that I don't understand, and I'm sure you don't as well, is the fact that, as I said, it is curable, it is a low-hanging fruit, and it costs almost nothing. I mean, what we speak here is really ridiculous, and these are real figures. What you need to do as a first step for children with TB is to find them. And that's when you go and you have an adult with TB, it costs you just a question to say, do you have children and can you bring them that we make sure that they are not infected or not sick with TB? If they are, if they are to be prevented to develop tuberculosis, the preventive treatment for a child is 3 cents a day. And it's a pill that you need to take for 6 months. It's 3 cents a day, and we can avoid all these things. And the treatment is 50 cents a day. For me, being in 2012, and I know all of us are dreaming the same, it's unacceptable why we still face so big tragedies at this small cost. I'll go to the fact. I want to underline and I'm going to the title of my presentation actually, and telling you why I think that the U.S. leadership was crucial in all the things that happened for TB, and why I think and we think that the U.S. leadership will be crucial for achieving further into the TB control. As you saw already, but I want to underline these things for you, and you saw already in the presentation of Dr. Ariel, there are 46 million patients that were detected and treated in 1995, 2010, and this is translated into 7 million lives saved, 2.5 million women and children, and the mortality reduced by 40%. The Global Fund that benefited directly from a big contribution from the U.S. government, benefits from represents the biggest funder for TB. As I said, 82% of the external funding is coming there. And important for you to notice is that from the entire bucket of money that Global Fund received, and they voted for TB, HIV, and malaria, TB got just 15% of this money, for whatever reasons. We don't go there now. With this 15% of the money, however, saved TB claims 50% of the numbers of lives saved in total by the Global Fund, which makes very clear statement about the cost effectiveness of the TB interventions. Now that's not something that is rocket science, because the treatment for TB, leaving aside the kids, cost for 6 months, cost $25, okay, for 6 months. For most of us in the room here, $25, let's be clear, is the cost of a lunch, and even not a lunch in a fancy place. For most of the people of the world, $25 for those that are with TB might mean a death sentence, or might mean a sentence to a different type of life. So I think we need to keep these things in mind when we are thinking of what we should do next. Now, why is the U.S., I'm saying that the U.S. leadership is the leadership indeed that matters. Money will come after that, but it's the leadership and the vision that it matters. And that's because of the arguments that I put it already. You heard that we have people that are there with TB, and we need to detect them. You heard already from Carol about the TB-HIV co-infection, and I'll go back to that. There are the merging of the TB and HIV. It's one of the biggest drama, and we succeeded, all of us, to make HIV as a chronic disease. We succeeded with the treatment. The people living with HIV are having a somehow decent life. But as you heard from Carol, we have TB, which is coming, and 1 in 4 people living with HIV are dying because of TB. So you have now the people with HIV having a pretty good existence, but because of TB, we are seeing a big impact on the number of people dying with TB. And that's something we all need to think about, because all the nice investments and targets that we have in HIV will not be achieved, I'm sorry to be that blunt, without proper investment in TB. We will be stuck, and we will see that more and more coming up. As you can see, unfortunately, we have a form of TB which is called drug-resistant TB. It's called multi-drug resistance, extensive drug-resistant TB. It's a form that takes 2 years to treat, costs here in US, and this figure I heard it yesterday from Dr. Ken Castro from CDC, $500,000 per case to be treated. It's a 2 years treatment. It costs a lot in terms of money, but it costs a lot in terms of human suffering, because it's a horrible treatment with horrible side effects. You vomit your brains out, and then you want to kill yourself. Not because you vomit, because of the side effects of the drugs. So God forbid any of us to have MDR-TB, and God forbid any of us to have a child with MDR-TB. And that's why we need to think about this, and we need to think to those that are less lucky than we are, and have MDR-TB, and have no access to proper diagnosis or treatment, and they know that they are sick, and what drama this represents. So, because we have all these challenges in front of us, we have as well we are doing pretty well, as you already saw, in reaching our 2015 targets. But we need to sustain what we gained. You know, it's like we went half of the way. We did very well. There are few steps, and always the last steps are the most difficult, that we need to make sure that we are reaching our 2015 targets. And that's why I'm saying that this is about, I said about leadership, and it is about as well as sustaining and leveraging the investments. I'm not going into this. I told you about the HIV investments will be lost unless we pair them with TB. Investments in childhood TB, it doesn't need to be a separate track. It can be very simple done, linking it with the already existing mother and child programs. The mother and the child are the same human being. It goes to a healthcare facility for a type of care. TB should be there. TB should be part of the package offered, and when we establish and we start programs, TB is a low-hanging fruit, and what was already said, I think, by everybody here. So it's something that we should look forward together to do. We are looking to all of you here in the room, as Executive Secretary, as the Stop TB Partnership, for your support, for your understanding of what TB means and what are the risks, but as well for your becoming sort of TB champions in pushing forward that not only the attention to TB, but the funding of TB remains there. And then we have very often being called over the last few years of the fact that we have a need for bolder targets in TB. So we are looking for your help in helping us to achieve the MDG targets for 2015, but as well in there more and becoming more in TB, and to start having the 0 deaths for TB as one of the Stop TB targets post-2015. I want to leave you with a nice photo of a little girl that was cured for TB, and that's because she was so brave, and she wanted to take the pills not crushed, but as they are, and she was almost crying every time, but she was able to hold her tears. These are dramas that are happening over there, but it's in our power, and it costs almost nothing, and we have all the evidence for that in order to have this stopped. So thank you very much for your attention.
Thanks very much. We do have some time for question and comments, but I'm going to just make a couple of comments quickly, just based on what we've heard today. One is, I think, a really important point that came out in Tika's presentation. We've heard about, and I've talked about, the need for new tools to fight tuberculosis, and we absolutely need those tools, and we're making progress on them. We shouldn't, however, mistake that for thinking that we can't make progress with the tools that we actually have, and that we haven't made progress. The 40% decline in mortality since 1990 is evidence of that. The reality of the situation is that we need to do both. We need to walk and chew gum at the same time. We need to roll out what we have now at scale, aggressively, and bring along these new diagnostics, new vaccines, new drugs to treat TB. And second, I just wanted to underscore the point also that Lachika made about the importance of U.S. investment in tuberculosis control. And there are really two vital channels in particular. One is that the U.S. is the largest contributor to the global fund to fight AIDS, TB, and malaria, the largest source of donor funding for tuberculosis, and really the driver in scaling up TB treatment for people that previously didn't have access. And the bilateral tuberculosis assistance provided through USAID is absolutely critical. By far and away, the biggest bilateral donor to tuberculosis is USAID. They support the development, some of the product development work that's going on. They support the strengthening of TB programs in high-burden countries. And although we would like to see a little bit more money requested and certainly more money given for that program to really expand that work, it's really vitally important when you look at the sort of big donor landscape of who's actually funding tuberculosis. So with that, I think we've got about 20 minutes for some questions and comments. So please. Sorry, 25 minutes. Please, go ahead.
I don't see any questions. So
Sorry,
yeah.
please identify yourself before you.
Hi, my name is Alberto Colorado. I'm a patient advocate. I used to run the binational tuberculosis and AIDS referral program in San Diego, California. During those years, I followed the patients moving back and forth, Mexico and the United States, but also around Latin America and around the world. And